the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're talking about Still's disease and hyperinflammation. Still's disease is often described by all the familiar features that we learn about in medical school: quotidian fevers, rashes, arthritis, elevated inflammatory markers. However, in some patients with Still's disease, the immune system doesn't simply just become active. It actually becomes difficult to shut down. All the signals that are meant to coordinate inflammation begin to amplify one another, and the result can be Macrophage Activation Syndrome, or MAS, a condition that really can look like infection, sepsis, malignancy, or even a severe disease flare. But the problem is that it demands a different level of urgency. This creates a very difficult problem. MAS must be recognized before every criterion is met, and it must be treated before every uncertainty is resolved. The patient may have an infection and a cytokine storm. They may have Still's disease and macrophage activation syndrome. The correct diagnosis may not be one thing, but several things happening at once. So how do we recognize when inflammation has crossed that threshold? Which clinical patterns and lab tests matter the most? How should we interpret a ferritin? And how should we act quickly without pretending to have more certainty than we already do? My guest today is Dr. Randy Cron, Director of Pediatric Rheumatology at the University of Alabama, Birmingham, and an internationally recognized expert in Still's disease, macrophage activation syndrome, and cytokine storm syndromes. We discuss why Still's disease is so closely linked to MAS, why hyperinflammation may be much more common than clinicians realize. We discuss how to recognize it at the bedside and how emerging treatments are changing the way we respond. Enjoy. Randy, welcome to the show.
Thanks, John.
So we're going to talk about macrophage activation syndrome. And I want to start with a big picture. I think many rheumatologists may not see macrophage activation syndrome very often, but certainly it's very important that if they encounter it, that they actually identify it and treat it quickly. Why do you think it's so important for rheumatologists to recognize MAS, even if it's fairly rare?
Yeah, and it may not be as rare as we think. That's the famous statement that you may not have seen MAS, but it might have seen you. But it's important to recognize in part because it's highly fatal. Depending on what populations you're looking at, it's 50 to 70%. So recognizing it is really important because if you don't recognize it, you're definitely not going to treat it and things aren't going to go well. And like I said, I think it's probably more common than we think. It's one of these things that's not a diagnosis of exclusion. As much as I love Occam's razor, this is not that. So you can have lupus, you can have lymphoma, you can have Epstein-Barr virus. But on top of that, you can also have a clinical setting, much like sepsis in a way, is not really a diagnosis of exclusion. You can have bacteria growing in your blood, but you can also be septic, right? So in the same way, MAS is something you need to keep your eye out for, particularly in patients who are kind of sicker than you expect them to be.
Got it. So is the problem that physicians aren't aware of MAS, or that they may get fooled by the patient who presents with what looks like sepsis or infection, and they're just sort of treating that?
Yeah, again, it is not a diagnosis of exclusion, so you have to keep it on your radar. I think as pediatricians, we're a little more attuned to it because there's a familial or genetic form that presents in infancy. And so we're kind of more attuned to it. But to be honest, there are 3 or 4 times as many adults, at least in this country, as there are kids. And it affects adults equally well. So it's probably much more common actually in the adult world. It's just whether you recognize it. And in part, the diagnosis is tricky, and we may get into some of the details of the various criteria that are out there for classification or diagnosis, but those aren't ideal either. And that sometimes makes the diagnosis tricky to say, I don't meet these criteria, so it's definitely not that. Well, that's often not the case.
Interesting. And I think there's also a lot of confusion with the nomenclature. I mean, we're talking about macrophage activation syndrome. Some people talk about HLH or secondary HLH. There's the cytokine storm syndromes. Can you sort of walk us through how you think about all this terminology and sort of give us a framework on, are they all the same? Are they different? And how should we think about them?
Yeah, that's also what makes this a little tough. I personally am a fan of cytokine storm syndrome as kind of an umbrella term because it kind of unites everything that way. So we don't have to argue, is this HLH, is this MAS, is this primary, is this secondary? But cytokine storm syndrome, I also think it's easier for the lay public to kind of wrap their heads around because hemophagocytic lymphohistiocytosis is a mouthful, or HLH. On the other hand, there are oncologists who are wedded to that because, right, that's the term they developed early on before the rheumatologists called it macrophage activation syndrome. All these are not identical, but they do have a lot of overlapping clinical and laboratory features. There's a lot of similar pathophysiology, and therapeutically, they respond pretty similarly, not identically. So again, it's not black and white, but I like this concept of cytokine storm syndrome, which got a whole lot of attention during the pandemic, obviously. And we had actually, myself and my colleague Ed Behrens, one of my former trainees, put out a textbook we titled Cytokine Storm Syndrome specifically for that. And it came out right before the pandemic. And I think in part that had a little bit to do with the attention that terminology got. But people are often wedded to what they are. And I would hope we change the cytokine storm syndrome, but I don't know if that's going to happen anytime soon.
Got it. So I guess we should try to unpack that a little bit more. There's the HLH terminology that is used by oncologists. Are they using that primarily in patients who have malignancy, or do they use that in patients with rheumatic diseases?
It's all over the place.
Okay.
So it initially evolved for children, infants in particular, who presented with this severe hyperinflammatory syndrome that we call HLH or cytokine storm syndrome from homozygous defects in the perforin pathway, including the gene perforin itself. And these children essentially will die if they're not treated. And if they are treated, then they roughly a coin flip survival. It's a little bit better than that if you're at one of these outstanding medical centers who's very familiar with it. But it's a terrible disease. And anyway, so that it evolved for that. But then people started realizing there are these secondary forms, including what the pediatric rheumatologist termed macrophage activation syndrome, mostly in kids with systemic JA or Still disease, that are similar, but are clearly not homozygous defects in the perforin pathway. But it turns out that actually some of these kids, not in adults too, have heterozygous defects, some of which probably contribute to disease. So it's, again, very blurred what's primary or familial and what's secondary, because there are probably genetic contributions as to why some people get these disorders with the same infection, for example, and other people don't. So it's complicated. And I don't think there's a simple way to break it out. But a lot of the oncologists, because they're so wedded to the HLH, they'll call like Still disease MAS, rheuma HLH, right? More and more terms, or infectious HLH, or malignant HLH, or MH. So it even is worse than it even sounds, right? Because there are all these reactive HLH, secondary, primary, familial. You take your pick, it's a mess. And that's another reason I really like cytokine storm syndrome, because it kind of envelops all of this. And again, it's not to say that these are all identical, but they share a lot of common features, even diagnostically and therapeutically. So that's my personal bias.
I like it. So within the rheumatology spectrum, you talked a little bit about systemic JIA and Still's disease is one of the diseases that may increase the risk of MAS. Can you talk a little bit more about, is that the only one? Should we, as a rheumatologist, consider other diseases as well? And if you have any sort of thoughts about why, in particular, those diseases are more prone to developing this cytokine storm syndrome.
Yeah. On the pediatric side, for rheumatologists, amongst our patients at least, systemic JA or Still disease is the most common, in part because and that's only about 1 in 10,000 kids. On the other hand, 10% or 10 to 15% will get overt macrophage activation syndrome as part of that disease. And another 30 to 40% will get like a subclinical or occult form of that disease that actually can go on to be fulminant MAS. So even though it's a rare disease itself, it's very prone to get MAS. And not entirely clear why that is. It's got, in addition to a later kind of autoimmune component, it's got an autoinflammatory component early on. And interleukin-1, for example, is one of these drivers of macrophage activation syndrome, and it's often very high. And particularly in patients with Still disease, one of the interleukin 1 family members, it's regulated very similarly. Interleukin 18 is extremely high, particularly in the setting of macrophage activation syndrome. It's elevated in still disease in general. And there are very few things, for example, that will give you a screaming high IL-18. So that's one, still disease. On the adult side, as a rheumatologist, the most likely place you're going to see this, because it's a more common disease than adult still disease, is lupus. And it's often at presentation. And a lot of the features of lupus, both lab and clinical wise, can be confused or confounded with macrophage activation syndrome. So you may have a new, and it's often at diagnosis. So you may have a new onset lupus and they're pancytopenic, and you think, oh, okay, that's their lupus. Well, maybe not. Maybe they're sicker than you might expect them to be. Maybe they're in the ICU, and maybe their pancytopenia is part of the coagulopathy that comes with macrophage activation syndrome or a cytokine storm. And so it's a tough diagnosis in lupus. And then in general, essentially any of our rheumatic diseases can do this. It's just some are much more likely than others. But you can even see it in spondyloarthritis, certainly in inflammatory bowel disease, where some of those patients get arthritis as well. It's been reported many times. But you take your pick, dermatomyositis, whatever, IgG4, they all can do it. But the most likely on the adult side is going to be lupus. And on the peds rheumatic side, it's going to be still disease. But the other thing I will say is, because we have these drugs that treat these conditions, and because we diagnose it in our patients, at least in our situation here in Birmingham, for our peds room service, the number one consult we get on the inpatient service now is macrophage activation syndrome. And that's my own fault, and I'm glad. And I think that's starting to spread among both peds and rheumatology programs across the country. We're getting consulted more and more for this, even if it's not our own patients, because we have a little bit of understanding of it from our own diseases, but we also are familiar with the therapies that we use to treat this. And so we get consulted on infectious causes. Often, if it turns out to be oncologic, then the oncologists typically take over. But another important point to make throughout all this, and I know I'm kind of rambling here, but is that a team approach to this is really important. So having the oncologist, the infectious disease docs, the immunologist, the rheumatologist, sometimes the hepatologist, the pulmonologist, certainly the ICU docs, involved in making decisions about these patients is extremely helpful.
So at Birmingham, do you have some sort of protocol that helps, some algorithm that prompts residents in the inpatient service to page you guys if and when these criteria are met? How does it work?
We do have it. It was started a few years back by actually one of the pediatric oncology fellows who was interested in this, and she developed this very nice algorithm, like you described there, that kind of steps you through. If you're considering it, get these labs, get this kind of workup, and it takes you down these pathways, and it even starts telling you when you might start considering treatment approaches to this. And there are several, at least children's hospitals, that have algorithms like that. They're all pretty similar. They're not identical, but they're pretty similar. So yeah, I think in here, specifically at Children's of Alabama, I've been here 19 years now, but it took me 12 years, and one of my greatest achievements was getting a serum ferritin onto the sepsis pathway, whether it was through the emergency department or the ICU. It took a change in leadership in the ICU, but eventually we got that on their pathway. And that's one of the reasons we get consulted so much, because it's a pretty sensitive screen. It's not all that specific, but it's pretty sensitive for finding a cytokine storm like MAS. And so we get a fair number of calls regarding that.
Amazing. I think I totally agree with you. If you're a pediatric rheumatologist, you have a patient with known Still's disease and they have prolonged fevers and cytopenias, you're automatically going to consider MAS. I think the challenge is in those patients that don't have a prior rheumatic disease diagnosis. Maybe it's their first presentation of Still's, or in the adult world, maybe it's their first presentation of lupus and they're presenting with MAS, or they may have infections or malignancy. Talk a little bit about what are the sort of the clinical features and the laboratory features that should get us thinking about MAS, or thinking about maybe consulting rheumatology, or thinking about maybe I should get some additional labs to see if this is one of those cytokine storm syndromes.
Yeah. So number one, 96+% of patients with the cytokine storm are going to have fever. But a lot of people in your hospital are going to have fever. But these are patients who tend to be sicker than you would expect them to be, even if you kind of have an idea of what's going on. Okay, this patient has this type of infection, for example. And they just tend to start getting sicker faster than you would expect.
Hmm.
So again, the serum ferritin is a real easy screen. It's a fast test. It's a cheap test. Most places on the planet can do it. My personal bias is if you're sick enough to be hospitalized, child or adult, anywhere on the planet, and you have a fever, those two things, you're in the hospital because you're sick and you have a fever, you should get a serum ferritin the day
Hmm.
you arrive,
Hmm.
if not the instant you arrive. And if it's low or if it's kind of marginal or whatever, fine. If they're still getting sicker, check it again. If not, you may be able to take cytokine storm syndrome off your radar. But if it's high, then you can start working them up and we can go into what kind of workup that would include.
Randy, what's your definition of high? Is it like above 1 point above the upper limit of normal, or is it
Yeah,
500 or
it depends on the
1,000 or?
labs, obviously, but like
Mhm.
200 is often 200 nanograms per mil is often a cutoff value or in that ballpark. I get excited around 500,
Mm.
but don't get too excited till it's at least over 1,000
Okay.
typically. But we've seen bad MAS like with the 700, for example,
Hmm.
and it can go up really fast. So it may be 700 today and it may be 10,000 tomorrow.
Hmm.
Certainly anything in the 10,000 range or higher, and certainly in the 100,000s range should really get your attention. There are some things more on the adult side than on kids, like chronic red cell transfusions that say you have sickle cell or some other reason
Hmm.
you're always getting red cells. You may be hanging out in the 2 to 3,000 range at baseline. So you got to keep that in
Hmm.
mind. Or if you have like chronic liver disease or something like that. But for the most part, if you are a previously healthy individual, child or adult, and you've got a fever and a high serum ferritin, that should get your ears up and or your back of your hairs up to get your attention to start working them up. And for me personally, I also start treating them with the stuff that we know helps, but is probably pretty benign otherwise.
We'll talk about that. Aside from the ferritin, anything else that should get us thinking about MAS?
Some of the very basic labs, right? Like a CBC is incredibly valuable. So thrombocytopenia is bad. Yeah. And so even a platelet count of 180,000 in the setting of severe inflammation is bad. That's considered normal, I think, in most places, but that's bad. And certainly trending down would be bad. And we know from mostly from retrospective data, but from other data as well, that a platelet count under 100,000, either at diagnosis or at any point in the disease process of a cytokine storm, is a risk factor for mortality.
Hmm.
So CBC, pretty simple. Again, basic test. I like the comprehensive metabolic panel because not only do you get kidney function, but you get liver enzymes. So liver enzymes tend to go up. They're easy to track. They tend to go up pretty quickly. Those are two very basic things. The C reactive protein, if it's IL-6 driven, will go up. It doesn't always go up, but it typically goes up in the setting of a cytokine storm. The erythrocyte sedimentation rate is interesting. It will often go up in the setting of inflammation. But if the DIC or this coagulopathy ensues as part of the macrophage activation syndrome, it will start to fall because fibrinogen is one of the primary drivers of your erythrocyte sedimentation rate. And as that gets consumed and is no longer sinking the red cells, it's your set rate starts dropping. So if your
Hmm.
patient's getting sicker clinically and or other markers are going in the wrong direction, like the CRP is going up, but their set rate's coming down, that's usually ominously bad. So those are kind of our basic four that we use for a lot of stuff, at least in
Mhm.
Pete's room, the CBC, CMP, set rate, and CRP. But then if you really want to start pulling into like the components of this, so the coagulopathy, most people will get a fibrinogen. And again, it often starts out high as an acute phase reactant. But if it's trending down or if it's low, that's not good typically. D-dimers are super sensitive, but when they're like over 10,000, or depending on how they're reported at your institution, that's not good. And so those are kind of some simple things. Triglycerides are part of some of the criteria. I find them kind of helpful, not so much. Sometimes I'll get an LDH. So those are just kind of the ones that don't take a lot of time to come back
Hmm.
or are not send outs, for example, that you can easily get.
Mhm. Yeah, I think those are great and sort of great to think about when you see patients with those abnormalities and start really considering MAS and consulting your rheumatologist or oncologist or infectious disease doctors to try to sort this out. You mentioned, send out tests and more specific tests. Talk a little bit about that and, what do they add that you don't already have when you have somebody with, elevated ferritin and a picture of MAS otherwise?
Yeah, so send out labs are problematic in a couple of ways. One is they can be expensive, and that's not always feasible for
Mm.
everyone, and they take time. Now, there are certain labs that will get it back to you within 2 working days. Those are pretty good. you have to be aware of that if you're going to do that. So the ones that a lot of us send out, a soluble CD25 or a soluble IL-2 receptor alpha chain is what that is, typically coming off activated T cells, which are often part of the pathophysiology here. And it's part of some of the criteria. So if you're going to use criteria, that may be helpful. And they also tend to track. So some of us will get them at onset and then maybe once or twice a week to kind of track them along with the other things we're tracking. The other one that I think is incredibly valuable, particularly to get early on, is the chemokine CXCL9. Interferon gamma's got a short half-life, and a lot of it is in the tissue. And so it's very hard to measure in the blood to get kind of a reflection of how important gamma is. And gamma is particularly important for some subtypes, actually many of the subtypes of cytokine storms, particularly familial HLH, but others as well. And CXCL9 is an indirect measure, but it correlates pretty strongly with interferon gamma activity. So if your CXCL9, which again is mostly going to be a send out at most institutions, is high and notably high, then it gives you good reason to consider blocking gamma interferon. So we have a new drug available to us, emapalumab, which is a monoclonal antibody to interferon gamma. And so if your original treatment approaches are not helping, and yet the CXCL9 is very high, then it gives you good reason to use that. The other option would be Janus kinase inhibitors that inhibit interferon gamma signaling downstream of the receptor through the JAK-STAT pathway. And so they're pretty good at blocking gamma as well if they're like a JAK1, JAK2 inhibitor like ruxolitinib, for example.
Right. So in your mind, the value of the soluble IL-2 receptor and CXCL9, are they more specific for these cytokine storm syndromes? Because like ferritin, as you mentioned, can be elevated in somebody getting transfusions or having liver disease. And the cytopenias could be lupus or malignancy. Do you find that there are other conditions that similarly cause very elevated levels of the soluble IL-2 and the CXCL9?
Sure. Anything that's going to drive up gamma, like infections, for example, are going to do that. It's just in the setting of your patient, right? And so you got to take the patient as a whole. But again, the CXCL9 I find valuable for therapeutic reasons because if you started treating them with steroids, for example, and IL-1 blockade, and they're not getting better or they're only slightly better, but the CXCL9 is telling you need to block gamma, then you're going to probably jump to emapalumab or a JAK inhibitor to see if that helps. The other send out that a lot of us are using, particularly in the setting of still disease, is interleukin 18. And that there are very few things outside of a few rare inborn errors of immunity, genetic causes of disease, outside of still disease that will give you screaming high, like over 18,000 or 20,000 IL-18 levels. And if you're in clearing the diagnosis, like maybe it's onset of still disease, that's going to really push you that way too. So, and that's something you can also track, but probably not daily. Obviously, it's a send out lab. Those are kind of the three send out labs, in addition to genetics, which is my own kind of personal thing. But in terms of really trying to help them in the short term, those are the three that you'd probably want to send out early. The other thing I would add, though, is that a lot of physiology, even in a secondary form, is similar to some of the familial form in that the perforin pathway may be disturbed. And so you can send out natural killer cell function, and there are killing assays. The one I like a little better is a degranulation assay. It measures a protein called CD107A or LAMP1 on the surface of the cell when it is activated. And that will be diminished if you have a defect in the perforin pathway, with the one exception of perforin itself. So it won't change if perforin itself is defective. But you can also measure perforin levels if you want to go that way as well, if you're concerned specifically about a perforin mutation. But it might give you an idea that they have a genetic contribution to poor natural killer cell function.
So what is actually happening sort of immunologically in patients that are experiencing these cytokine storm syndromes? Can you talk a little bit more about the pathophysiology and what cells are being activated and what's working and what's not working?
Yeah, it's complicated because there are probably we know there are multiple pathways to get to a cytokine storm, but the one that's been by far the most studied and probably is the most common is reflective of the familial form, which also occurs in some of these secondary forms. And that is this defect in the ability of cytotoxic either CD8 T lymphocytes or natural killer cells. They share the same perforin pathway and their ability to kill, let's say, an infected cell or antigen presenting cell. And if they have a defect in that pathway, then number one, they're not going to kill a virally infected target cell, which is going to help shut down the viral life cycle, for example. But the other thing that's interesting is that they spend more time engaged with each other. So let's say a CD8 T cell recognizes a flu-infected antigen-presenting cell, like a macrophage or a dendritic cell, and normally they would kill it through the perforin pathway. They would make an appropriate amount of pro-inflammatory cytokines like interferon gamma or TNF, and the APC may be making some interleukin-1, for example, or gamma. And so when it doesn't kill either at all, like in the severe familial form, like a homozygous perforin deficiency, or in a partial defect, there's more time engaged. And for the familial form, it's been shown it's actually 5 times longer than normal. And there's actually the dying cell through a caspase dependent mechanism will tell the lymphocyte to take off and go kill someone else. So that's what happens appropriately. When it's inappropriate, they just sit there and they crosstalk. So instead of making the appropriate amount of interferon gamma or the appropriate amount of TNF, they're making supernormal amounts, which is thought to lead to the pathophysiology of the multi-organ system failure.
Amazing. So when you're getting biopsies on patients who have liver disease or whose bone marrow is not working or who may have lymphadenopathy, what do you actually see? What are the cells that are sort of invading and causing tissue damage in these patients?
Yeah, different organs are going to be different. The liver tends to be one of the primary organs for a lot of these diseases. And it's important to point out clinically that often, unless it's a respiratory pathogen, the lung is not. The lung is a late thing, and the kidneys tend to be a late thing. So by the time your lungs are failing and your kidneys are failing, you're typically pretty far down the road. But on a bone marrow biopsy, and this is often helpful, well, certainly if you're trying to rule out leukemia, for example, that's helpful, or metastases. But if you see hemophagocytosis, then these are these giant activated macrophages or histiocytes engulfing multiple other cell types, white cells, red cells, et cetera. That's also compelling that maybe a cytokine storm is ongoing. If you just took normal people's marrow, you would find hemophagocytes at a very low level. So it's not an absolute, but in general, you will see much larger hemophagocytes, like engulfing multiple different cell types and or just more of them. And it's important to point out because hemophagocytosis, or what you find either on bone marrow or other tissue pathology, is neither highly sensitive nor highly specific. So it's about 60% when you look in these patients. So, if you don't see it, it doesn't rule it out. And I think people sometimes have that problem. And if you do see it, it doesn't prove it either. But it's more kind of, again, the whole picture, putting it together, that may be what's going on.
Interesting. And Randy, you've mentioned a lot about sort of genetics and this familial HLH where patients have like homozygous mutations in perforin genes, and certainly they get sick very early during infancy. But is there a role of genetic testing, an older child, an adult who's presenting with one of these cytokine storm syndromes? What are your thoughts?
This is what I do, my lab does. So I try to get genetics on everyone I can to try to better understand all this. Whether it's ultimately going to make a difference is hard to know at this point. And I will say it's controversial. So there are some people, I think there's more of us who believe it than don't, but there's some people who think that having a heterozygous defect in these pathways because it's not homozygous does nothing. And there's some large databases that may kind of make that argument. That's kind of the genotype to phenotype. I do the reverse, which is phenotype to genotype. So because some of these mutations are relatively common, there's a perforin mutation called A91B, for example, that's present in about 8% of Caucasians in the United States. So very common, and it is pathologic. It's mildly pathologic, and that's probably why it's relatively common. Then there are other common ones in MUC13.4, for example, in the Chinese population, for example. So I would venture to guess that 15 to 20% of us are walking around with the heterozygous, sometimes multiple, mutations in this perforin pathway. And we haven't discovered all the genes that are involved in that either. And so there are probably other genes we just don't know quite yet to look for. But for example, we did this study a while back in 2009 when H1N1 reared its head and killed a lot of people worldwide, including in the US. These pathologists at the University of Michigan reported deaths in previously 30, 40, 50-year-olds from H1N1, right? And a lot of us get exposed to these viruses. A lot of us get these viruses, but very few people end up in the hospital and or die from them. And the reason these pathologists reported this was because they had these findings of hemophagocytosis all over their pathology. And so we contacted them, and through our colleagues in Cincinnati at the time, we did genetics on the samples that were left. And of the 14 samples, 5 of them, or 36%, had mutations in the perforin pathway, including 2 patients who had both a perforin mutation and a LIST, which is another gene in that pathway, suggesting that it's higher than you'd expect in the general population, and that these are risk factors. So just because you have this mutation doesn't mean you're going to get it, because clearly 20% of us aren't dying of cytokine storms, but there's a threshold model of disease that I and other people like, where let's say you're carrying one of these mutations. It could be mild, it could be not so mild. You're basically fine until you're not. And so maybe you've got underlying inflammation like lupus or leukemia, and maybe you're still okay. And then you get Epstein-Barr virus or something that pushes you over the threshold at which your immune system can no longer tolerate this amount of inflammation, and you get a cytokine storm. Whereas if, for example, you're homozygous perforin deficiency, most of these are going to present in the first year of life, if not the first few days, weeks, or months when they get their first virus, for example. It doesn't take much. But for most of us, maybe 20% of us who harbor one of these potential contributing mutations, we're fine until we're not.
Very good. Going back to the patient at the bedside, you mentioned all of the labs that you typically send, including sort of the basic stuff and the send outs. Do you find the criteria for the HLH 2004 criteria, the H score, the SJIA, MAS criteria, are those helpful? Do you use them, or how should we think about them when evaluating patients that may or may not have MAS?
Yeah, that's a great question. So I personally go by Gestalt, but I've been doing this for a while. These patients, and I've certainly heard about many of these patients. The 2016 systemic JIA criteria, which were built for kids who had systemic JIA and nothing else, they actually work pretty well for systemic JIA and for adult onset still disease, with the caveat now that a lot of these kids and adults are on interleukin 1 or interleukin 6 blockers. And those things do things like block fevers, or they may raise your liver enzymes, right? Or lower your cell counts. And so if you're already on one of these medicines, the criteria still perform pretty good, but not as well as they initially did. So they're not perfect, but they're pretty good specifically for still disease, both pediatric and adult. They weren't designed for adult, but most people who have studied in adults with still disease say they perform pretty well. The HLH criteria, which were developed for the familial or the genetic cause of this disease, if you wait for that 5th criterion, particularly because a couple of them are not easy to get, like the soluble CD25 or the natural killer cell function, or people may not have done a bone marrow, for example, to look for hemophagocytosis, your patient may be dead when they finally meet that 5th criterion. So that's not good. Jan Ingehenter and others who helped develop these, we published a relatively recent paper that you can probably get away with just 4 of those. But again, I tend not to employ them just because I don't want to miss it. I'd rather be more worried about it than not. And they're okay. They're pretty good. They're not perfect. And again, different triggers and different causes of cytokine storms are going to work better or worse for those criteria. And then the H score, which doesn't matter what kind of HLH you have, with the caveat that it was based on adults primarily with cancer-associated HLH. So you take that for what it's worth. Plus, they're additive. So you get different scores depending on how high your fever is or how low your cell counts are, for example. And then you total them up, and then they give you like the percentage chance you're going to have a cytokine storm. And so if you're missing data, that's going to lower, again, you're going to lose sensitivity. So nothing is perfect, for sure. I think they're helpful and I use them to teach the medical students and the residents all the time, calculate this for me, because they're easy to do. Even the H score, which is got all these numbers and stuff, there's online calculators. It can go really fast if you have the data. I'm not saying not to use them. I'm just saying that they're not the be-all, end-all. And so I do personally go a lot by Gestalt, but I also go ahead and calculate them and see what you get. And is it compelling or not compelling? Because you're trying to get the whole picture here. And I will say, at the bedside, particularly when you're trying to follow the course of the patient, you don't need a lot of fancy stuff, right? You can look at things like fevers or how many pressors they're on. Are they on less pressure? Are they on less vent support? Really basic things, right? That you don't need fancy labs to follow. I mean, I do get labs. I like data, but look at your patient, right? They're going to tell you more probably than anything.
I love it. So, Randy, you and I are evaluating a patient, either 15 or 50, at the bedside who has features that smell like these cytokine storm syndromes. How do you start? And you get the basic labs that you mentioned. What do you do next? Are you trying to look for what the trigger is? Are you thinking about treatment right away? Are you doing both simultaneously? Walk me through your thought process when you're at the bedside with one of these complicated patients.
I'm typically trying to do both. If you can find an infection, great, because if you treat the infection, that's going to help you a lot. I think it's good to send off some of these RNA PCR based, like really broad searches for things because they're not 100% sensitive or specific, but they're pretty good. And if you have a pathogen to go after and you start treating it, that's going to help no matter what. And in fact, sometimes that's all you need, but I don't tend to do that. Just use antibiotics, for example, or antivirals or whatever. And there are certain bugs that you need to kind of be on the lookout for. So herpes virus family members are notorious. So Epstein-Barr, CMV, but any of them can do it from HSV to HHV6 and 8. They all can do it. And there are funny bugs like Ehrlichia that parts of this country tend to trigger it. And then depending on where you are on the planet, like dengue may be the number one cause of cytokine storm syndromes around the world. Leishmaniasis in other parts, right? And so I think you need to screen for infection because, again, these are all not diagnoses of exclusion. You can have leukemia and then you can have a Candida bacteremia on top of that or whatever. So yes, and if you're worried about cancer, you should have your oncologist involved and they will help guide you on what you need to do from there. In terms of treatment, I'm a big fan of the recombinant human interleukin-1 receptor antagonist, anakinra, because it's relatively benign. It's something your own body makes. It's not going after cells like most therapies we have. But nowadays with biologics, we can go after individual cytokines. In this case, we're basically blocking the ability of interleukin-1 alpha or beta to bind to its receptor and signal through it. It can do a few things, like rarely it can raise your liver enzymes. Usually that goes away if you stop it or lower it. It's also got a ginormous therapeutic window. There's very few drugs you can give 20 times the normal dose and get more benefit without side effects. You can give it IV, you can give it sub-Q. It's got a really short half-life. So even if it was problematic, it's gone before you know it. It's like 4-hour half-life if you give it sub-Q, for example. So if I'm compelled enough to believe that a cytokine storm is there, and I don't know what that percentage would be in my mind, like 70 or 80% maybe, I'll start recommending it. Now, not everyone on the team may want to do it, including your ICU docs or your infectious disease docs. Although really, it's not a broad immunosuppressant like steroids, right? Like steroids are fabulous drugs for these conditions, but you often have to worry about cancers because you'll mess up the long-term treatment if you start treating cancer early with steroids before you know what's going on. Or for infections, it certainly may make things worse. But I've also seen it save lives in the setting of infections, like influenza, for example. So steroids are really great drugs for these conditions. It's just not something that a lot of people are comfortable using right up front. So that's one of the reasons I particularly like anakinra.
Can you talk a little bit about the doses that you typically use? Is it just 100 a day or do you titrate up quickly as you need?
Like a lot of things that I personally treat, I like starting high and going down if I can.
Okay.
And I actually start kind of in a medium range for anakinra, which may be high for a lot of people, which so for an adult is 100 milligrams every 6 hours. And for kids under 40 kilograms, we tend to give 10 mgs per kilo, divided maybe Q12 or whatever. So, but for the average adult, 100 Q6, you can go higher and you can give it continuously IV. People have done that too. And sometimes that helps, sometimes not. But it does have a ginormous therapeutic window. And the other good thing about it is when it works, you're going to know within 48 hours if it's working. It may not be perfect and you may need to do something else, or it may not work at all, but you should know within 48, at least by 72 hours if it's working or not. And so that's why I like starting it early. The other reason I like starting it early is we have retrospective data that suggests that the sooner you start it, the better your outcomes. So waiting tends not to be good for these conditions, no matter what you're treating them with. But at least for anakinra, we have retrospective data that suggests that the earlier you start it, the better your survival. So for a drug that's really not got a lot of side effects, that is often effective, it's got a short half-life, it's got a ginormous therapeutic window, I always say, like, why not?
I love it. I think one of the challenges would be, you start somebody on Q6 anakinra, they don't seem to respond. Are you climbing up the wrong tree or are you under treating those patients? How do you think about that and what would be your next step?
I would say if there's a partial response, then I may increase the dose if I
Mm.
think it's helping. But if it's not helping at all, they either don't have a cytokine storm or they don't have a cytokine storm that's responsive to IL-1 blockade. And again, so if you start the anakinra and you send off the CXCL9, it may be back depending on where you sent it within a couple of days. And now you see the CXCL9 is 300,000. You're like, okay, time for gamma blockade, whether it's emapalumab or one of the Janus kinase inhibitors.
Very good. So is that how you sort of think about patients that aren't responding to anakinra? You sort of wait for the labs and see if there's other clues as to what may be the sort of pathophysiology of a specific patient's disease?
Yeah, again, if you send off a pretty broad infectious workup and or you've got your oncologists involved or you're working them up for some autoimmune or autoinflammatory condition, you may have closer answers to what's going on at that point, and that may guide you a little better.
Hmm. And when or how do you think about using steroids? You mentioned that they're very useful, but they kind of cloud your picture about malignancy and maybe not great for some infections. When do you think
Yeah,
about using them?
again, it's kind of a team answer to that. And their intensive care docs often have this thing, I'm not going to let someone die without a trial of steroids. But you don't want to wait too long either, right? And the other thing is like a lot of conditions in rheumatology, but this as well, if glucocorticoids aren't helping you, you're in trouble. Like there's very few things that we have in our bag of tricks that's going to help if steroids don't.
Yeah.
And then the question is, how much do you give? The oncologists like dexamethasone in particular because it's got
Mm.
better CNS penetration. But when we give like a pulse of methylprednisolone, for example, we're often given 5 times the glucocorticoid equivalent of what they're given with dexamethasone. So I'm like, sure, add your Decadron on top of my Solumedrol.
That's amazing. Can you talk a little bit about some mistakes that you've seen clinicians do when either evaluating or treating patients with MAS or these cytokine storm
Yeah.
syndromes?
When I first got here, one of our oncologists was consulting on a child who ended up ultimately having MAS. And this individual did not want to treat this child because they had not met the 5th criterion of the HLH04 criteria. But we just finally convinced others that was probably not the best approach. And that kid ultimately did okay in the short term. In the long term, he ended up dying of cancer many, many minutes
Mm.
down the road. And we didn't know he had cancer at that time either, even though we got multiple biopsies, including multiple marrows. So number one, don't completely wait for that 5th criterion. That I think is a good lesson.
Mm-hmm.
I think getting ferritins as soon as you can is again going to be helpful.
Yeah. I really like that idea of sort of you have a fever, you're in the hospital, get a ferritin. I
Yeah, why
think
not?
that's brilliant.
It's cheap, it's easy, it's fast. There's very little downside to it,
Yeah.
And when people develop these sepsis protocols, right, they're thoughtful in that they don't want to throw everything at you, right? But this, I think, is a really important one to add to that because even with sepsis, we know that a subset of those patients have a cytokine storm in addition to their sepsis. So you're really breaking Occam's razor, right? They've got some bug, then they've got a state of sepsis. And then in a subset of these patients, I don't know what percentage that is, maybe 10%, maybe smaller, are having a cytokine storm as well. And if you don't treat that aspect of it, things are not going to go well.
Yeah, yeah. You mentioned that these cytokine storm syndromes are not a diagnosis of exclusion. So let's say you start anakinra, you're doing your workup, and a bug comes back, or the patient has lymphoma, or you figure out that they have lupus. Do you stop the anakinra, or do you continue treating sort of the cytokine storm aspect of their care and think about sort of disease-specific treatment? How do you think about sort of that dichotomy?
If the anakinra is helping, it tends to be the last drug I stop because it's beneficial and it's got the least amount of side effects. I'll often wait till they're off steroids or on at least a minimal dose, even when they're out of the hospital before I ultimately stop the anakinra in particular. But a lot of times these patients are on steroids or other things. And again, if they have an infection, we're going to treat that, but I'm not going to stop treating the cytokine storm. But again, you can look at them at the bedside and you can get some really basic labs. Are their platelets coming back up? Right? Are their liver enzymes dropping back down? Are they off the ventilator? Are they off their pressors? Whatever it happens to be, are they not bleeding out of every orifice, right? So you can, again, just look at your patient and get a feel for how they're doing clinically. But I have very little reason to stop the anakinra. The other thing I tend to do, because in the US we have insurance issues, right, is the instant I ever consider using anakinra, at that moment I also get people in our office to help start the process of getting anakinra on the way out the door,
Oh, amazing.
because otherwise that's going to keep them in the hospital.
Yeah.
And actually, the company that markets anakinra, Sobi, is pretty good, even if insurance doesn't approve it right away, to give you a 2-week supply to get you through those initial days out of the hospital.
Yeah, talk about some of those long-term outcomes. Let's say somebody does make it out of the hospital because you were smart enough to identify these cytokine storm syndromes and treat them early. What's the outcome? Like, how do you manage them?
Yeah, and it's going to completely depend on their underlying disease if you identify one. And I'll have to say, in a lot of these patients, we never know what triggered it or what their underlying disease was, unfortunately. But I will say that outside of still disease, we're a subset of patients, and not all still disease patients do it, but those who get MAS often get it over and over again. Very few diseases do that. Certainly the homozygous ones, if you don't treat it, are probably likely going to do that or just continue on in that sense. But for most of the secondary ones that show up later in childhood or in adults, if you survive your HLH, and I don't have great experience because I'm a pediatrician, but so I don't follow them throughout the rest of their life, but I get the impression that if you survive your event, you're likely not going to get it again, which is pretty awesome. I did have, for example, an 18-year-old girl who came to me, who was previously healthy. She was a competitive barrel racer, so she was an athlete and was previously healthy. 2 weeks of fever and belly pain was what got her admitted to the GI service. But after about a week of hospitalization, they called me and said, come back with this kid. And she had pretty bad MAS. And she ultimately had a heterozygous mutation in one of these perforin pathway genes, and a gene called RAB27A that we took back to the lab, did a lot of work on, and really tried to demonstrate, at least in vitro models, that it was probably contributing to her disease. And I saw her a couple of years ago, 10 years later, and she had never had an episode like that again. And there was another patient we included in that paper who was a colleagues in Rome, Italy, had a 14-year-old boy with the exact same mutation, heterozygous RAB27A, same mutation, and he did well. And actually, both those patients' fathers had the mutation and had never had a cytokine storm. But they did have half normal killing function at baseline, both the parent and the patients. So I saw her a few years ago because now she's a mother and has a son. And she's like, should I get genetics, right? And you were asking about this early. I said, probably not, because what are you going to do with that, right?
Mm-hmm.
I would say if your son gets hospitalized and has a fever, please beg them to get a ferritin, because that's the most helpful thing to know. Not that he necessarily he's got a 50% chance of having the RAB27A mutation. And at that point, you may want to get it. But it's very unlikely that child, just like her father, is going to get a cytokine storm. It's possible, right? They're at higher risk than the general population. But what's important to know is if you are hospitalized and you have a fever, and that's a lot of kids, obviously, and adults, get a ferritin.
I love it. Just one last question, sort of hinted at earlier, when you have a Still's patient on an IL-1 or an IL-6 inhibitor, understanding is they can still develop MAS, but as you mentioned, they may not sort of present sort of classically with fevers. How do you think about recognizing MAS in a patient that is already being treated on these cytokine inhibitors?
Yeah, so the MAS is going to present a little bit different than a disease flare, for example. So unlike that classic board question, salmon-colored evanescent rash that comes and goes with the fever, they may often, and this is not just systemic J, but many MAS patients may have a more kind of just almost fixed rash that could be anywhere, right? It's going to be a different rash than the typical still disease flare rash, for example. And even though when you're having a flare of your still disease, you're sick, again, these patients are sicker than you'd expect them to be, right? They're likely going to be in the hospital. They may be in the intensive care unit. If their platelet count is, the platelet count is really going to be helpful, because if it's a still disease flare and they're not in MAS, it's often 500, 600, 700,000, 800,000, whatever. Here, if it's 200,000 and they're really sick and inflamed, that's not good. So there are some ways that you can distinguish. It's not always perfect, but a still disease flare from still disease MAS, even if they're on an IL-1 or an IL-6 inhibitor, which may be somewhat lowering, like particularly the IL-6 receptor monoclonal antibody may be lowering their neutrophil count and raising their LFTs a little bit. And both of them, the IL-1 and IL-6 blockers, are pretty good antipyretics. So they may be blocking the fever.
Amazing. Randy, this has been an awesome conversation. I hope that everybody listening will now start thinking about getting ferritins in any hospitalized patient with a fever. And hopefully we'll do a better job of recognizing these cytokine storm syndromes and have a better idea of how to treat them. So I really appreciate your time. Thank you so much.
Yeah, it's been my pleasure.
One of the central lessons from this conversation that I took away is that MAS doesn't always present as a neatly defined diagnosis. More often, it appears in a patient who is becoming much sicker than expected. The diagnosis emerges from the pattern, perhaps a rising ferritin, falling platelets, worsening LFTs, a declining fibrinogen, and a clinical course that no longer fits an uncomplicated infection or an inflammatory flare. Dr. Cron also reminded me that MAS is not a diagnosis of exclusion. For instance, finding an infection, malignancy, lupus, or Still's disease does not end the diagnostic process. The underlying condition and the cytokine storm may both require treatment. So perhaps the most useful question is not simply what is causing this patient's illness. It's also, has the immune system become part of the illness itself? And I think the practical pearl is straightforward. When a hospitalized patient has a fever and is becoming sicker than expected, just check a ferritin. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep your differential broad, your threshold for checking a ferritin low, and of course, stay healthy.